The US spends about twice as much on healthcare than other large and wealthy countries do.
It's just a complicated product, and people have a hard time figuring it out, which is unfortunate because it's such an important product.
People are recognizing the importance of having available, affordable, quality services.
You have to make the commitment to provide health care for everybody. That's the destination. It turns out there are many different routes to that destination.
Healthcare spending is rising around the world.
As far back as we've been measuring this, healthcare spending has always risen.
Overall spending on healthcare has doubled over the past 2 decades, reaching $8.5 trillion in 2019, which comes out to 9.8% of global GDP.
The US spends about twice as much on healthcare than other large and wealthy countries do.
The U.S. healthcare system is not as effective when it comes to controlling costs compared to systems in other countries.
The way the system is structured now, it is cure-driven system, not a prevention-driven system.
There is not one access model here in the United States. And so for preventive services, for treatment, it really depends on people's insurance status, where they're located, and the provider network near them.
It is extremely frustrating for not just patients, but physicians also.
The way we do it, by definition, makes things much more expensive for the U.S.
So why are U.S. healthcare costs rising more than anywhere else? And can it be stopped? Healthcare spending made up 5% of total U.S. GDP in 1960. In 2020, spending hit almost 20% of total GDP.
So what that means is that for every dollar that people spend in the US, about 20 cents is going towards healthcare.
This rise in spending can't be attributed to inflation alone.
Healthcare almost always outpaces inflation, and so, healthcare costs grows faster than the economy. That's why it's representing a larger and larger share of the economy.
The United States spends more per person on healthcare than other high-income countries, but still has a lower life expectancy.
We have poor outcomes relative to other countries. We pay twice as much as any other country. We pay more and get less.
We see that people in the US use a similar amount of healthcare to people in other wealthy and large countries, but we pay more for each interaction. The money's in hospitals and doctors. That's what makes up the big difference between what we spend on healthcare in the US and what other countries spend.
Hospitals, physicians, and clinical care made up more than half of total healthcare spending in 2019.
When we talk about ways to reduce spending, you can either look at ways to reduce the amount of care that people are getting or to reduce the price that people are paying for their care. And in the US, it seems that there needs to be more of a focus on the prices of care, because that's where the real difference is between what we spend in the US and what other people spend in other countries.
Drivers of the rise in healthcare spending has focused mostly on the symptoms of the rising healthcare spending. So when we are talking about hospitals, prices are very high, or drug prices as very high. These are not the causes of the high spending. These are the symptoms of high spending.
One of the causes of high spending is the fragmented nature of the U.S. system. Some Americans have incredibly comprehensive and affordable health insurance coverage, while others have little to no coverage.
For some people, they might spend a very small share of their income on healthcare, and that's usually because they're healthier. People who are sicker will spend a very large share of their income on healthcare, especially if they're in private insurance coverage with a high deductible plan.
Over 11% of the U.S. population was uninsured in 2020, with a large disparity when it comes to race. 51% of Americans said they have delayed or skipped medical care due to cost. That number jumps to 63% among those living in a household with an income of less than $40,000 per year. Even those covered by insurance say they've experienced financial trouble. About 46% of insured adults reported difficulty affording out-of-pocket medical costs. The WHO argues in a 2021 report that universal coverage would limit catastrophic health spending. This lack of universal coverage can make costs rise while also leading to worse healthcare outcomes, specifically when it comes to preventative care.
When costs become prohibitive for patients to seek care is that, number one, preventative care and preventing diseases from getting worse is always going to cost less. And the cost meaning to the overall system is always going to cost less.
Let's say somebody has no insurance or very little insurance, and she feels a vague pain on the right side of her abdomen. You know, it would cost her $120 to go to the doctor. She's not going to do that. She's going to work through it. And 3 months later, she's in the emergency room, a burst appendix. It costs $60,000. And we'll treat her. We'll treat her. But if she could have gone to the doctor when she felt that first pain, the doc could have treated the infection. It would have cost $100.
There is a phenomenon in healthcare called the cost shifting. Cost shifting happens when healthcare organizations shift the cost of those who cannot pay the bill to others who are covered by insurance providers by increasing the prices somehow.
We also have to take into consideration the concept that, maybe 30% of these bills will go unpaid, which can be thousands of dollars. So at some point, if you want to keep your practice afloat, those have to be recouped in a different way.
This is a factor of the US healthcare system where how much people end up paying is going to depend on your insurance.
A lack of universal coverage and a fragmented healthcare system also mean that people don't have the same insurer for their whole lives, which means that insurers have less of an incentive to provide preventive services or to ensure that you don't get sick later.
The majority of Americans don't have much of a choice when it comes to their insurance plan. More than 54% get health insurance through their employer.
Capitalist view works when the market is free. Healthcare is never a free market.
Instead, we have insurance companies bidding on patients' behalf, which limits patients' ability to bargain with their healthcare providers.
We have what the insurance companies call narrow networks, where they dictate which doctors you can go to.
Patients also can't bargain because they usually don't know how much care actually costs.
One key requirement in a free market is to be informed about the price of the product or good you are purchasing. But in healthcare, patients are in the dark about what would the cost be when they seek their care.
Insurance makes prices even more opaque, not just for patients, but also for doctors.
Sometimes it is difficult to know upfront what a patient's costs are going to be for whatever services that they're getting. At the end of the day, we are actually not the ones controlling the rate for each different company. And even if we have a whole list of every single possible charge, we don't know if people have met their deductibles yet. We don't know where they are with respect to out-of-pocket maximums. We don't know, what their copay might exactly be, if it's a percentage.
A lot of care is delivered through what's called fee-for-service. That means for every service that your doctor delivers to you, that doctor is billing for each individual thing. And that can create an incentive called provider-induced demand, which is basically that your doctor has an incentive to do more things to you.
But it's more complicated than just greed. America's litigious culture can play a role in excessive testing.
I do think that in the United States, we do order more tests simply because, one, there's this fear of missing something. Of course, that comes from a human aspect where you don't ever want to misdiagnose a patient. But then there's also the malpractice side of things, where if you do miss something, what are the consequences?
Since there isn't true free market competition, insurance companies will try to rein in the spending by either denying claims or requiring pre-authorization.
Most physicians are doing the right thing and choosing the right treatments for their patients. But sometimes there are instances where the procedure that's being requested may not always be the most effective treatment for their particular patient. And sometimes the prior auth process also serves as kind of a gatekeeper, so to speak, of whether that physician has tried everything that could potentially help the patient.
There are proponents for completely overhauling the heavily commercialized system.
You have to make the commitment to provide health care for everybody. That's the destination. It turns out there are many different routes to that destination.
One of the more popular policy proposals is Medicare for All, which would replace for-profit insurance companies with government-funded health insurance.
I am a strong supporter of Medicare for All because it is our principal goal in this country to give everyone coverage at the lowest possible cost, and Medicare is the best way to do that.
President Joe Biden is instead focusing on expanding the Affordable Care Act to enable more people to get insurance. There's also been a bipartisan push for increased price transparency. Congress passed the No Surprises Act, which went into effect in January 2022. The goal of the legislation is to help Americans avoid surprise medical bills.
Now people who inadvertently go to an out-of-network provider, for example, by going to an in-network hospital but being seen by an out-of-network doctor, that patient is held harmless. And then it's up to the insurance company and the doctor to kind of work out how much gets paid to them.
Researchers and economists are still debating what exactly is driving these costs in the U.S.
It's very hard for people to know how much healthcare is going to cost them before they get it. Some of that can be addressed through price transparency efforts by basically posting prices on hospital or doctor's offices' websites.
Research has to be intensified in this area to clearly identify the root causes of the high spending and the interrelationship between the different routes.
There's a lot of moving pieces here, and there's probably not going to be one single solution to healthcare costs and access and quality of care and insurance coverage, but there's a lot of different directions that policy is starting to go in terms of actually addressing the healthcare costs in the U.S.
It's an open secret among Americans that calling for an ambulance is a financial gamble. According to one study, 71% of all ambulance providers do not take the patient's insurance. That same study found that 79% of patients who took an ambulance could get a surprise bill, with an average total around $450. And when nearly 4 in 10 Americans would have to borrow money to cover a surprise $1,000 emergency, these surprise bills can be a huge problem. The COVID-19 pandemic has exposed wide inequities throughout the American healthcare system. And like the rest of the healthcare industry, ambulance operators are feeling intense financial pressure from the crisis. So why are ambulance services so expensive in the United States? And what's being done to solve the problem? There's a broad price range for emergency medical services in the United States. The U.S. Government Accountability Office, or the GAO, found that in 2010, the median cost per ground ambulance transport was $429, ranging from $224 to $2,204 per transport. And that price can vary a lot by state. In 2016, the average price of an emergency ground ambulance in Georgia was $824. In New York, it was $752, $930 in Texas, and $557 in Florida. Even within the same state, the charges can vary widely. Take Florida, for example. In Lake City, Florida, the average charge for an emergency ground transport with basic life support services was $463. In Tallahassee, 2 hours west of Lake City, the average charge was more than $200 higher, at $680. In Miami, the average charge was $630, and Tampa's average was $590. A variety of factors contribute to this disparity in price, including the type of ambulance used, the medical services rendered, how far the patient was transported, the state and city the ride was taken, and whether the ambulance service was publicly or privately funded. There are many types of organizational structures when it comes to running an emergency medical service. They could be privately run or funded by the municipality and work in conjunction with other entities such as the fire department. They can also be a volunteer organization that's funded through private donations and grants. Art Cook and David Sloan work at Westfield Volunteer Rescue Squad in Westfield, New Jersey. The rescue squad is funded completely by grants and donations from residents and businesses in the town, so there's no out-of-pocket charge at the point of use.
We're lucky that we live in a very generous and affluent community, so we don't generally have difficulty raising the funds.
Because all of the rescue squads, dispatchers, and EMTs are volunteers, the organization can operate without high staffing costs.
As with any labor-intensive organization, your highest cost is going to be payroll.
Supporting a nonprofit ambulance provider through donations can be tough for less affluent areas, as well as dense urban areas with high call volumes.
If a less affluent town were not able to meet the fund requirements of that individual rescue squad to be able to supply their ambulances, or if they have a problem getting volunteers to be able to operate that system, each town would look for an alternative to be able to provide ambulance service. And more often than not, that either becomes contracting with a private ambulance service, or which is a cost, or hiring EMS personnel under the auspices of their police or fire department.
Many patients who get surprise ambulance bills can trace them back to for-profit companies.
My name is Karan Chabra. I'm a resident in the Department of Surgery at Brigham and Women's Hospital. Surprise medical bills happen when you get medical care from somebody who you were unable to choose, and that person or that provider doesn't take your insurance. So in those situations, if they don't participate in your insurance plan, they can charge you whatever they want to be paid.
Dr. Chabra and his colleagues recently released a study that evaluated insurance claims from a large national insurance plan, focusing on the years between 2013 and 2017. The data couldn't tell them how many patients actually received surprise bills, just how many could have if the ambulance provider decided to bill them for what the insurance company didn't pay. They found the average patient could be charged $450 per ground ambulance ride after the average insurance payout. Contrast that to the potential surprise bill for an air ambulance, which came in at a staggering $21,700 per ride. Ground ambulances usually get the focus when it comes to surprise billing, even though they cost less than air ambulances. That's likely because ground ambulance rides are 55 times more common than air ambulances. Chabra's analysis found that potential surprise bills for ground ambulances over the 4-year period he studied would add up to more out-of-pocket costs overall than air ambulances. Despite being less common, air ambulance billings are trending upward. Chabra's study notes that potential out-of-pocket air ambulance fees are catching up, with a 15% annual increase in potential surprise billings for air ambulances between 2013 and 2017. Betsy Imholtz is an attorney who used to work on healthcare issues at Consumer Reports, a nonprofit consumer advocacy and research organization.
One of the arguments about why there's more air transport these days for medical reasons is that rural hospitals are closing. But we found, in fact, that there's a lot in metropolitan areas. Some would say the traffic has gotten bad, and so we need to even transport people locally in highly concentrated, populated areas. For whatever reasons, there's a lot more of it going on all over in all kinds of areas now.
Imholtz says one reason for this spike could be the air ambulance industry shifting more toward a for-profit model.
Between 2012 and 2017, more than 100 new helicopter bases were added, some of those in areas where there already were services, so they're duplicating services, not responding to higher demand.
When air ambulances first started to be used in New Jersey, they were run by the state police and didn't charge for their services. Now there are also competing private air ambulance services that are generally affiliated with hospitals.
In a normal functioning market, this would work. If there were more suppliers present in the market, then prices should go down. But the problem is that people in medical emergencies don't get to choose their ambulance provider. The ambulance provider is dispatched by a 911 operator. And since they don't have to take your insurance by law, they can charge you whatever they want. So there's no price competition. There's no pressure driving down prices.
In some cases, there's been an argument over whether patients' medical issues were urgent enough to warrant the use of air transport.
Some of the consumers that we interviewed felt that they had been unnecessarily transported by helicopter when they really didn't need to be. It was an urgent situation, but they felt that by the time the helicopter landed and picked them up and got them to the hospital, they could have even more quickly gotten there by ground transport. So it's very hard for consumers to know, was it really necessary or not? And often that's a fight with insurance companies. Was it medically necessary?
A big problem is that emergency medical services are expensive to operate. The amount of revenue that's generated from even the most efficient ambulance systems is limited by the fact that if you want the ambulance in your community to be available for you when you need it, that means they can only really be doing ambulance calls about half the time at best.
But not much data is available about how much ambulance services cost to operate. Asbel Montez is the Senior Vice President of Strategic Initiatives for Acadian Ambulance Service, as well as the chairman of the Payment Reform Committee for the American Ambulance Association.
We are one of the last industries to do any type of cost data collection, or what in most people refer to it as cost reporting. And that is something that we have advocated for as an industry. We do not have a mechanism like hospitals and any others that are actually having to do cost reports to validate their the Medicare payment system. That is not, we do not have that data yet.
The GAO and the Nonpartisan Medicare Payment Advisory Commission, or MedPAC, do collect some data regarding reimbursement rates for EMS providers. But those within the industry say the reports do not accurately estimate costs of service. The lack of comprehensive data also leaves some consumer advocates such as Imholtz concerned.
The question is, what is the real cost of providing this service? And are people price gouging? Are some of these companies price gouging? Because of the private equity control of many of these companies, we really don't have the data on what it really costs, how much is profit, how much is surplus, how much are unnecessary rides. They're just building up more supply than they really need to. So there's a lot of information lacking still.
Many private insurance companies consider most EMS providers out of network. This means the two entities do not have a predetermined agreement about how much the service costs.
The way reimbursement's set up right now, it's often more profitable for these ambulance companies to avoid contracting with the insurance companies. It's more profitable to stay out of network. So why would they bother, writing a contract?
The American Ambulance Association does not believe the concept of in-network or out-of-network should apply to emergency medical services.
There's really no such thing as an out-of-network 911 provider. You might be the city of, and I'm just going to throw out a name here, the city of Houston, who provides their own EMS services. If you as a citizen do not have a choice in who your 911 provider is, that is set by the mayor of that city and the city council saying the city of Houston, is the one that provides 911 services. How is that out of network? So the issue there that we've got going on is the insurance company is denying it wrong, saying the city of Houston does not want to be in our network, and so they're out of network. No, the issue is you don't like the rate that the city of Houston is charging.
In addition to private insurers not paying the entire cost of the bill, government-funded insurance plans such as Medicare and Medicaid don't cover the entire cost of the service either. A report conducted by the Moran Company, contracted by the American Ambulance Association, concluded that EMS providers lost money from Medicare and Medicaid rides.
That did conclude that we were being reimbursed below cost for Medicare. And then Medicaid, remember, actually reimburses less than Medicare does.
We often hear that there's cost shifting, that much more has to be charged of private pay or even uninsured people because the reimbursements either from insurers, Medicare or Medicaid, are insufficient. And we haven't really found the evidence for that to be valid.
So how much should ambulances cost patients out of pocket?
The main reason we have out-of-pocket costs for any healthcare is so that we don't use healthcare willy-nilly and without some rationale. So we want to discourage things like calling an ambulance for a routine stomach ache. So the out-of-pocket cost for anything should be just enough to discourage people from overusing ambulance services, but not so high that they discourage appropriate use or they make people go broke.
And the problem is you have to balance this out so that the patients don't get hit with a $3,000 bill, but at the same time, you want to also have some controls over utilization. So while you don't want bills that are going to bankrupt people, you do want bills, preferably some kind of payment at the point of service, which discourages people from utilizing an ambulance when they don't really need one.
There are some countries that do maintain low out-of-pocket costs for ambulance services. Take Australia, for example. Ambulance fees do vary in Australia from no out-of-pocket costs to more than 1,000 Australian dollars in certain regions. In some of the Australian states and territories where there are no out-of-pocket costs, many residents call for ambulances without actually having an emergency. Because this puts a strain on the system, Australia runs a public education campaign urging people not to call an ambulance if it isn't an emergency.
000 ambulance emergency.
Yeah, g'day. Look, I think I've sprained my wrist. I've had a cold for 3 days now.
Last year, Ambulance Tasmania received too many trivial 000 calls that could take us away from real emergencies. Save 000 for saving lives.
Rational people behave in rational ways. If you're poor and you could either have to call an Uber and pay for the Uber at the point of service, or you call the ambulance and not have to pay at all, people call the ambulance because that's perfectly rational.
Despite there being agreement on both sides of the aisle that this is an issue, it's been difficult to make progress on legislation.
It's been a completely bipartisan issue. There's been proposals that have been agreed upon by both Democrats and Republicans in both the Senate and the House, and remarkably, the Congress and the President have agreed on this as well.
Congress has taken some steps toward collecting more cost data for the industry in order to better understand reimbursement rates.
The Bipartisan Budget Act of 2018 did actually mandate a cost data collection provision to start this calendar year for the ambulance industry. Over a 4-year period, they will basically mandate every ambulance provider and supplier that bills the Medicaid program will have to, at a minimum of one time, report their data. And they will do an analysis on the system from all of the rates that we get paid based upon the different organizational types to understand where are we being paid inappropriately.
The legislation authorizes what is known as extender payments for ambulance services. These are Medicare add-ons that increase the payments depending on the area the providers are servicing.
Basically, Congress this time said, we want data from your industry. You keep telling us, based upon the GAO reports, the MedPAC reports, that we are underfunded, or you're reimbursing us under cost. Well, in order for us to give any more money in here, we'll extend these for 5 years, but we're going to mandate cost data collection.
Some states have also been working to pass laws to fill the holes of federal regulations, but they can be met with legal challenges.
There are many states that have tried to intervene to protect consumers on this, several of them at least. But generally, the industry comes right in and takes them to court and challenges the law. Under the CARES Act, one of the coronavirus relief packages, any provider that got federal funding through the relief package is actually banned from balance billing anyone with suspected coronavirus. Well, you can't help but think about our big healthcare system in the middle of this pandemic kind of crisis, and people are recognizing the importance of having available, affordable, quality services for us. And certainly in the emergency context, as we rethink the healthcare system, I hope that as a nation we will just really think hard about whether we want to leave emergency services on a catch-as-catch-can basis with unbridled for-profit companies without any rate regulation, or whether we really want to think this through carefully and have a system that ensures that every American can get the care they need without going bankrupt.
Most Americans pick the wrong health insurance plan. Sora Bhargava and his colleagues at Carnegie Mellon University conducted a study of almost 24,000 employees at a major Fortune 100 company. The study found that 61% of them chose the wrong plan for their needs. The researchers estimated that the average employee could have saved $372 per year by choosing a different plan.
The average cost of these choices was about 2% of salary.
In 2018, over 8% of Americans' total household spending went toward healthcare costs. This represents about a 37% increase since 2004.
It seems like people aren't able to maximize their welfare because they're having trouble understanding the decision environment.
It's just a complicated product, and people have a hard time figuring it out, which is unfortunate because it's such an important product.
So why do Americans struggle to pick the best plan for them? And how can we fix it? One major issue in choosing a healthcare plan is people don't understand the lingo insurance companies use to discuss each plan.
We usually ask every year, what is a premium? What is a copay? What is a deductible? And the results are usually pretty depressing. Only about a third of people usually correctly identify all three. These are the most basic terms to understand.
This basic lack of literacy, I think, contributes to a number of problems that people have exhibited when they do choose from a plan.
The way plans are presented to people makes it difficult to figure out exactly how much each plan costs.
People have trouble doing the math from the features to the consequences. We see things like what's the deductible of each plan, and what's the copay of each plan, and what's the maximum out of pocket of each plan. The part that's difficult is to actually then say, okay, so suppose next year I break my leg and I go to the hospital, how much money do I actually spend under each plan?
There are premiums, which is the amount of money people have to pay each month, regardless of whether they go to the doctor. This is the bare minimum someone would have to pay for their plan each year if they don't use any healthcare at all. There are also deductibles, which is a set amount of money a policyholder has to pay out of pocket in the beginning of each year before the insurance plan will kick in and start sharing costs. It's common for people experiencing information overload to hyper-focus on one aspect of a plan, such as how much the deductible is or how much the premium costs, rather than looking at the plan as a whole based on how much healthcare they'll actually use over the course of the year.
When you're in a decision environment that's complicated, is to try to simplify it for yourself in some way that you can. And often that's a rule of thumb, or what we call a heuristic.
But in some cases they can go awry. And I think in the case of a lot of health insurance contexts, the heuristics that people use result in them selecting overly expensive plans that end up costing them quite a bit.
A lot of people are basing their decisions on the absolute numbers they're seeing presented to them rather than calculating their financial risk with each plan.
One challenge that I think people have is that while plan choice really should be about your health risk and your willingness to take on financial risk, I think a lot of people, they look at more expensive plans and they see more expensive plans as being better. Almost like choosing a hotel.
Research has shed light on how to best help people determine the plan that makes the most financial sense for them.
Find that showing people the consequences improves the choices that they make.
The best way is to do the math and figure out how much a plan may actually cost over the course of the year based on how much healthcare the policyholder might need. One study gave people several health insurance plans to choose from. The researchers also gave the study subjects some help choosing their plans by laying out exactly how much each plan may cost based on how much healthcare they use that year.
We designed as this tool that allows you to see for every potential expenditure under each plan, how much money you actually are going to be spending over the course of the year in terms of both the premium you're going to be spending and then also how much you're going to be on the hook for relative to how much the plan is going to help you out with. And we could show it in a graph, and you can actually see some plans are above other plans in this graph in terms of how much money you're spending overall. And the tool helps people to pick a plan that over the course of the year, they end up on average spending less money.
Some employers and state-run Obamacare marketplaces are beginning to provide decision aids, such as calculators that help people make the best decisions for them. If you are going to do the math yourself, take into consideration your own health risks when doing so. That means considering the best case scenario where you may not need any care or just preventative care, and the worst case scenario where you need a lot of care. You should also be careful to check which doctors are in network within specific policies, because the doctor you go to can change costs dramatically.
If you have expensive health conditions or kind of a serious health history, I'm a cancer survivor. So I have a group of doctors who I really want to keep seeing because they've saved my life a couple of times. So it matters to me that, they're in my plan network. I can't necessarily guarantee that all of your doctors or the facilities that you go to, the treatment facilities and so forth, are going to be covered. So you're really going to have to check. It's not very transparent. So all the plans have a link to a provider directory, but you're going to have to kind of click into all of them.
It's also important to revisit a policy every year to see if it's still the best option that fits your needs, even if your employer hasn't made any changes to the plan.
So only 20-25% of employees in employer-sponsored contexts will actually change their plan from year to year. So if you choose a poor plan from a financial basis, then normally you stick with that plan for, potentially multiple years. So it can become quite a costly choice.
There are places for people to turn to get assistance.
If you are looking at marketplace coverage anywhere, there are navigators. These are trained experts who can help you walk through the application, answer any questions. What am I supposed to fill in here? And help you kind of sift through the plan choices and try to figure out how they're different and which one works best for you.
Picking the wrong plan means people are spending more money on healthcare than they have to, and the numbers show it. Healthcare costs in the U.S. have been rising overall due to a variety of factors, including out-of-pocket expenses for Americans. Healthcare spending in the United States has gone from 6.9% of total GDP in 1970 to more than 17.5% as of 2019.
When we are spending that amount of money on healthcare, that money is not available for other sectors of the economy.
The average American household is also spending more on healthcare. According to federal data, average deductibles in employer plans more than doubled between 2008 and 2017, from $869 to $1,808. Cost of living as a whole is also getting more expensive, which puts more pressure on Americans because wages have not been keeping up with this increase in prices. The average household income in the U.S. increased by 27% between 1984 and 2020. In that same time period, the average American household spending on food rose 155%, spending on housing rose more than 160%, and out-of-pocket spending on medical care rose more than 390%. This burden of incomes not keeping up with costs has implications for what kind of plans Americans are drawn to. High-deductible plans can be a big problem for a lot of people because they may not have the cash for it.
The recent proliferation of high-deductible plans across the employer-sponsored landscape is that there's a real worry about liquidity and being able to pay for out-of-pocket costs. These liquidity concerns are also driving people to select what end up being fairly expensive plans.
Bhargava's study found that employees earning less than $40,000 per year were much more likely to select a plan that would end up costing them more money. Lower income employees were also less likely to switch their plan each year, and even when they did switch, they were less likely than higher income employees to switch into the highest deductible plan.
The high deductible plan tends to be the better value over the long term because that plan, you're paying a lower premium. And then under many states of the world, especially the ones where you're relatively healthy, you end up paying less over time.
Ultimately, economists say that the whole system needs to be simplified in order to provide plans that are higher quality while also being more affordable.
Whereby we get rid of a lot of the complexity of cost sharing and replace it with just a much more simple, much more transparent menu of options.
But attempts to make the actual costs of plans clear can backfire. For example, on the Affordable Care Act marketplace, which is frequently called Obamacare, people are presented plans using a metal tier system. A plan could be labeled as platinum, gold, silver, or bronze. These are meant to help people understand the cost-sharing features of each plan. So the platinum plans have the most financial coverage. The insurance company would pay 90% of costs at time of service, and the policyholder would pay the remaining 10%. The trade-off is that those plans have a higher monthly premium. At the other end of the spectrum, a bronze plan has the least amount of cost-sharing support. The insurance company pays 60% of the cost of service, and the policyholder pays 40%. Research shows that people are misunderstanding the metals, thinking they're actually a reflection of the quality of the plan rather than the amount of money they'll end up paying in monthly premiums or out-of-pocket costs at time of service. President Biden signed an executive order in July 2021 that aims to improve cost transparency and standardize plans on healthcare.gov starting in 2023. The goal of the order is to make it easier for people to compare across plans. Several states such as Maine, Massachusetts, Oregon, Rhode Island, and Vermont have rolled out budget comparison tools to help people navigate the state's local health insurance exchanges.
Well, I think giving people access to this type of data in a way that is simple to understand would definitely be helpful. Having more information that is easy to understand is very important.